This is the Psychcast by MD Edge, where we bring you interviews with the leaders in the field of psychiatry and psychology, masterclass lectures, and relevant inspiration and reflection, with new episodes dropping on Wednesdays. I'm the voice of MD Edge Podcasts, Nick Andrews. And welcome to episode 121 of the Psychcast by MD Edge. I am Nick Andrews. Dr. Norris is away this week and will not be joining me for the intro. Coming up in this week's episode 121, we're going to be speaking with Dr. Sheldon Preskorn about the coronavirus and COVID, and we'll preview that more in a moment. A quick reminder that episode 120 in your feed, if you scroll down, is our special conversation bonus emergency episode about race in medicine, treating patients during protests and civil unrest, and perspective from two African-American physicians in psychiatry. That's episode 120. We thought that would be the best way to respond to the civil unrest in the United States in late May, early June in 2020, the explosion of passion at the murder of George Floyd. So instead of doing something specific on any one Psychcast, we thought we would create a space to have that conversation. That's episode 120 in your feed. Okay, this week in the Psychcast, our guest is a little bit different. We're talking with Dr. Sheldon Preskorn, and Dr. Preskorn is with the University of Kansas School of Medicine in Wichita. The conversation this week is all about the best way to educate patients about the coronavirus, SARS-2, COVID, the way it works, the way to talk to patients about it, which is something that I had never considered as a producer, but it makes a ton of sense and something that should be covered here. So without any further ado, please welcome Dr. Lorenzo Norris and Dr. Sheldon Preskorn.
This is Dr. Lorenzo Norris, Editor-in-Chief of MD Edge Psychiatry. We're privileged today to have with us Dr. Preskorn. Dr. Preskorn is a professor of psychiatry, and he is going to speak with us about COVID-19 and how we can maybe as psychiatrists understand some of, if you will, the manifestations, the maybe a bit of the epidemiology around COVID-19 in a way in which we can actually speak to our patients about this and answer maybe some of the common questions that they may have regarding COVID-19. So if you're like me, COVID-19 invariably is a topic that comes up in your period in your psychotherapy sessions and your psychopharmacology sessions. So hopefully this, if you will, podcast will give you some additional tools in which to think about and engage in those conversations with patients. Dr. Preskorn, welcome to the MD Edge Psychcast.
Thank you, Dr. Norris.
Okay. So Dr. Preskorn, one of the things that comes up in regards to COVID-19 or coronaviruses in general is how did we get here? What is the, where did this come from? People have a difficult time understanding it. How is it different from other coronaviruses they may have heard? And maybe you could walk us through maybe how you might approach talking with a patient and helping them understand what coronavirus, COVID-19 in particular, is and is not.
Okay, very good. Well, so the history, first of all, one thing one should know is there are hundreds of coronaviruses. They primarily infect animals, and particularly bats, but a number of other mammalian species. There are 4 coronaviruses that have been known to infect humans for years and probably date back to the 1200s. Those 4 coronaviruses are one cause of what we know as the common cold. However, things changed in the year 2000. Mm-hmm. And from the 2000s to today, we've had 3 coronaviruses jump from animals to man. The first was known often as SARS, or sudden acute respiratory syndrome virus, now known as COVID-1. And it was quite lethal, killing about 10% of people. And one was concerned in the early 2000s that it might become a pan-epidemic. It was so lethal that probably limited its abilities. About 6 to 7 years later, a second coronavirus of this more lethal type that can cause SARS, which is sudden acute respiratory syndrome, was known as MERS. And it came prominently to our attention in the Middle East, and hence it was known as the Middle East Respiratory Syndrome virus. And the last so far has been SARS, sudden acute respiratory syndrome, CoV-2, which is the virus that causes COVID-19. So that was the backdrop in December and January to the emergence of this virus out of China. And that was the reason for the concern with it.
So, Dr. Preskorn, you bring up some, you paint, if you will, the coronavirus history, particularly over the last, if you will, since the 2000s very well. A question that patients may bring up, or I know that they have, is this trying to understand the difference between SARS, MERS, and currently COVID-19. Like, why are we so concerned about COVID-19 as compared to SARS? Because for most people, obviously right now, COVID-19 seems to be having a much more impact on their daily life than SARS or MERS. So that's a question that people may get from their patients. Why is COVID-19 such a big deal? Whereas with SARS and MERS, it felt like a big deal, but we didn't do all of this. I mean, how would you approach that with patients?
The difference is there are three main differences with COVID-19 or SARS-CoV-2. Mm-hmm. One, it is highly transmissible. Mm-hmm. It will infect, for every person infected, they will infect up to 6 additional people. That was much more so than with CoV-1 or MERS. 2, this virus is sort of sneaky. It stays hidden, and you can be infected for many days and shedding virus before you're ever symptomatic. And that's the reason why it can be subtle and can sneak in. And 3, it is much more, it's not as lethal as the other 2 viruses, which allows it to propagate, whereas the other viruses killed the host before they could propagate. And so it has 3 features that make it dangerous: highly transmissible, a long period between shedding the virus and being symptomatic. So you can't count on the person being asymptomatic to mean they're not infected. And 3, while it doesn't kill most people, it is very lethal in individuals who are elderly or who have comorbid medical illnesses.
Yeah. All right. So when I think about that, and I think about what you just outlined in terms of coronaviruses and colds, and I'm just trying to, if we can play around with this in terms of maybe some things that we might tell patients, depending on where they're at in terms of either their emotional state or distress or cognitive function. But I think about coronavirus as, just listening to you, this is what I think, like, it's as at least probably, if not more so, but certainly I would say it's certainly in the same vein as contagious as a common cold. All right. In terms of that, I would also say that it is more lethal than the flu. And then the other thing is, I like that word you use, it's sneaky.
Yes.
All right. It's sneaky. So we can't see it the same way we could the flu or the cold. And that's what makes all of those elements are what makes it so dangerous. So it's not the cold. It's not the flu. It's a sneaky thing that sticks. That kills more people than the flu. And that's why we're so concerned.
Yeah. Now it kills more people in special populations.
Okay, excellent. Yeah, let's break that down.
So in seasonal flu, in younger individuals, people under the age of 50, it probably is not substantially more lethal than the seasonal flu. But in individuals, as they develop comorbid medical illnesses, now when I said under 50, I mean under 50 and no comorbid medical illnesses that put you at high risk. And there are essentially 4 or 5 comorbid illnesses that put you at substantial risk. That's respiratory disease, including COPD, emphysema, and even severe asthma. Cardiovascular disease, particularly hypertension, morbid obesity above a body mass index of 40, and diabetes. And then the other is if you're immunocompromised. So if you're on steroids, if you're on drugs to suppress your immune system, those individuals, regardless of age, are at increased risk. But in addition, as you get older, you get at more risk. And so, for example, above the age of 85, your risk of dying from COVID-19 is between 10 and 27%. So it actually gets as lethal as COVID-1 and MERS in that population. And the trick is, and what patients need to know is that even if they're asymptomatic, or if the person they're visiting with is asymptomatic, they may be shedding the virus. And if they're in those high-risk population, if either they're visiting somebody who's in high risk or they are at high risk, they have to take extra precaution. And unfortunately, they cannot count on the fact that the person is not symptomatic to indicate that they're not infectious.
Yeah. I think you raised, there are very important points in regards to those two populations. One, in terms of, again, educating patients, particularly with the older population above the age of 85. I also think about when you talk to family members and they debate about, well, should I visit, grandmother or great this or that, or my father or mother, depending on what one's age is, or why can't I see them in a nursing home? And that helping them understand what you just said, that in that group, again, and we're just going to talking broad terms because we want to simplify for folks. In that group, COVID-19 can become as lethal as SARS or MERS, if you will. And people get that. A lot of people get that SARS was extremely lethal. So I find that helpful. The other thing in regards to I do think that the other thing in regards to the other population, if you will, where for the most part, we do not have the lethality, but unless there are comorbid medical conditions. Now here's a little bit of my pet peeve with the comorbid medical conditions. I know that you do a lot in terms of, I think you mentioned you do drug development, things of that nature. For those of us that treat patients with serious mental illness, and you use, if you will, take whatever, you pick up various D2 antagonists, a lot of our medications cause the metabolic syndrome. A lot of our medications cause diabetes. A lot of our medications do not help with CVA outcomes. And many of our patients do have respiratory illnesses. So I think that when I think about that, as you say, when I think about that, with an older population, we must be abundant of caution, and err on the side of safety. And I would almost say with everybody else, particularly in the population that I treat, constant vigilance because of, yes, if you are, for lack of a better word, a clean bill of health, sure, you may be able to view this in a different light, but that is not the general population that I work with. So I would say that we want to always have a high level of vigilance, because many people go around with these conditions and they're not diagnosed either, the comorbid medical conditions. So particularly with people not coming to the hospital because of social distancing and things of that nature. So I believe those are very, 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 very excellent points. Now, one thing I wanted to get into in terms of the patient education is the media. Okay.
Yes.
And the media, I mean, there are, depending on what news outlets you look at or things of that nature, certainly in weeks past, the media was reporting an ever increasing number of cases.
Yes.
Okay. Why was that? And what are maybe some of the challenges in interpreting what that means? Because I'll have patients they'll be looking at, take your pick, and you'll just see this number going up and up and up and up and up in terms of cases. And so how can we help our patients better understand that, what that means?
Okay. Well, so the original way that a case was defined was somebody who was symptomatic.
Okay.
When you went back to January, February, the way we defined COVID-19 was you had a fever, you had a cough, and you had respiratory distress. That represents perhaps about 20% of everybody infected with the virus. And those people are at risk to progress in their disease process to the point of severe acute respiratory syndrome, where you need hospitalization, you need ICU, you may need intubation. But now we have the ability to actually test people for whether they are shedding virus. And for example, there was a recent cruise ship that experienced an expeditionary research cruise ship to Antarctica, where they took great pains to ensure that people went on the ship had no symptoms, had no fever, had not been to any high-risk areas before they could board the ship. The ship never touched another harbor until it came back. They checked people's temperature every day. On day 8 of the cruise, the first person had a fever. They went on to develop the full COVID syndrome. As soon as that person was detected, they isolated everyone. But by the time the ship returned to harbor, 60% of the people were infected based upon shedding virus.
Okay.
81% of those people were asymptomatic. They had no symptoms. 19% had symptoms. The vast majority of those had mild symptoms, sometimes a cold, sometimes a mild flu. But 8 required medical evacuation off the ship because of respiratory distress, and 1 died. So that little cruise experiment, in a way, shows how the virus is very sneaky. So it can be sitting there. It was sitting in somebody for 8 days before it expressed itself. Despite the fact that they sheltered themselves, 60% got infected, 81% had no symptoms, but 20% had symptoms that were, maybe flu-like, but 8 had symptoms that were respiratory distress type.
Okay. And thank you for speaking to that, Dr. Preskorn. You've talked to us about a number of things now in regards to helping us understand coronavirus, how we can start to work with our patients. One thing I wanted to ask you, though, because you obviously have a bit of a skill set that I would say most psychiatrists do not have. And in this pandemic, I would say that psychiatrists, I can't speak for others, we are increasingly being trusted and relied upon by our patients to give information regarding coronavirus, social distancing. I will have some of my patients ask me, what are my views of this? What are my views of that? Because they trust me. In your opinion, in terms of that, the role of a psychiatrist in terms of educating patients on coronavirus, this is going to be a couple of questions. One, what is the best way that you would recommend that a psychiatrist can keep themselves up to date on the information and the newest developments? And I guess second, where would be things that as a practicing psychiatrist, you feel a psychiatrist can feel comfortable talking about, and then other things where we would have to maybe defer to our colleagues in infectious disease or someone of that nature? Please go ahead.
Well, So that's actually the reason for this podcast is I think that first one demystifies the illness. And so one understands where it came from. One understands its behavior. One understands why just being asymptomatic does not mean you're not infected. So I think if psychiatrists are aware of those things, and there's a history, the virus is a virus, and it's not mysterious. It started out mysterious because we didn't know very much about it. We only knew about the two previous severe respiratory distress syndrome viruses. And then we learned how this one was different. So in answer to your question, I did write a couple of articles that are on the web. And one in particular was entitled Protecting the Vulnerable and Opening the Economy, because there are really two things that one needs to do. Clearly, we can't have an economic shutdown indefinitely. That has untoward events. But we also have to realize that there is a subpopulation based on age, comorbid illness, and many of those patients, as you point out, many of those individuals, as you point out, Dr. Lorenz, are psychiatric patients because of metabolic syndrome. They may smoke too much. They may have emphysema. So they are part of that vulnerable population. And those individuals need to be protected because they're the ones in whom the virus can be quite lethal. And so I think probably the toughest thing is to realize you're a family member. You have no symptoms. You want to visit your grandparents, your parents in a nursing home. You want to visit your brother or your sister with a psychiatric illness. But just by virtue of the fact you're asymptomatic, it doesn't mean you're not infected and that you can't pass the virus on. And that's the reason for social distancing, because the virus passes by inhalation of viral particles from aerosolization. That's the reason why you have the 6 feet. And that's the reason why you wear masks, even if you're asymptomatic, unless you can be tested for shedding the virus before you go in to see them. Okay. Now, so I think if you demystify the illness and you understand some of the history, you may not want to go into 1200, the first coronavirus back to 1250 and bats well beyond that, but realize there is a history and things are known about it. And actually, for example, the genetic code for CoV-2, SARS-CoV-2, was determined in January of this year. And so we already know, what the nucleotide sequence is. Actually, it's an RNA virus. And that's why medications were focused on to potentially treat the disease and the development of vaccines. Okay. So I think what one thing that psychiatrists can do is to say, look, I'm a doctor, know certain things. Here are some facts I know. Right. I know why social distancing is important. I know why masks are important. I know why just by virtue of the fact you're asymptomatic doesn't mean you're not infective. And I know who the vulnerable population is.
Okay. Dr. Preskorn, I think that last, that to me is a very useful, if you will, way to approach it with patients in terms of, I'm a physician. This is what I know in terms of these broad swaths. I know how it's, I have an idea based off of the knowledge of how it's spread. I understand the danger of asymptomatic spread. I understand some of the theories or principles behind social distancing in wearing masks. And in addition to that, I have, along with my colleagues and other people, we have worked diligently to define populations that we need to be concerned about. But in all reality, this is a public health concern. So that's why we start with the spread and why we all have to be concerned. So, well, Dr. Preskorn, I think that you've given us some very valuable tools and a very good overview of kind of just some very needed talking point in regards to coronavirus, a certain language perhaps that we may be able to utilize in sessions with our patients that combines elements of the evidence base that is out there, along with, if you will, a very practical, matter-of-fact language to how we deal with this virus. So, and work with our patients to mitigate, if you will, all the secondary, and I won't say secondary, the mental health effects or consequences of just folks, either whether they have coronavirus, whether they have a family member with coronavirus, or they're going through everything in terms of social distancing, wearing a mask, and things of that nature. So, Dr. Preskorn, I want to thank you so very much for appearing on the Psychcast, sir.
Thank you. I was going to mention one more thing.
Okay.
There are those articles which are on the websites. And when you ask, how can you stay current? Many of the references are to websites that are updated on a regular basis, such as the Johns Hopkins website, such as CDC. And so if somebody's interested, the reference list gives you those kinds of websites that if you were interested in delving deeper into it or staying current, you can do it right from your computer.
I would, Dr. Preskorn, I would agree with you, and I actually make use of those sites myself. So very good. So Dr. Preskorn, thank you so very much for speaking with us, okay?
Thank you, Dr. Norris.
And that concludes the interview portion of our show this week. Big thanks to Dr. Preskorn for joining us. Don't forget that you can find more information about Dr. Preskorn as well as references mentioned in their conversation, a summary and an outline of the talking points, all in the show notes. The show notes are authored by Dr. Jacqueline Posada, who is an associate producer of the Psychiatrist. She authors our show notes, and she's been a producer and in front of the mic as well. Okay, when we come back, it'll be time to welcome Dr. Renee Kohansky. Welcome back to episode 121 of the Psychcast. I am Nick Andrews. It's time now for Dr. RK.
Thank you, Nick. I was listening to one of Dr. Norris's podcasts the other day, and he hit one of my sweet spots, particularly as a forensic psychiatrist. And that's the concept of decision-making capacity. And I'm going to actually take this into a broader context, I guess, if you will, and I'm going to go into our role even bigger as psychiatrists. So this was from the perspective of a CL psychiatrist. In forensic psychiatry, we often refer to it as competence, but it can be a confusing term, and I do prefer the term decision-making capacity because it captures the essence of the concept really, really much more succinctly. And this is all subsumed under the much broader construct of informed consent. In other programs, I've spoken about the three basic components of informed consent, which are competence or capacity, if you will, information, and voluntariness. I don't think we can speak about this concept enough in medicine. And in these times in particular, we owe it not only to our patients, but to the younger generation of physicians we are training, and actually to the public. And we need to review this as many times as necessary for people to understand this. So this is part one of a two-part series on some very critical concepts to medicine. And while it's a review, it's a timely review, and it's actually going to go into something even bigger. So I've said in other programs, the FDA doesn't tell us what medications to use, and we aren't even constricted by the intended design of a medication. For that matter, by the way, neither are the designers of the medications or the medicines or the candidates, as these compounds are called when they are being created. Minoxidil was initially designed to treat ulcers, but it was discovered to be a powerful vasodilator. So in clinical trials, people started getting actually very hairy. So rather than market it as an antihypertensive with side effects of making you hirsute, they marketed it as a treatment for hair growth with a side effect of lowering your blood pressure. See how that happened? So in informed consent, we provide patients with information about a medication, why it's being used, possible side effects, alternatives to treatment, possible outcomes without treatment. We might tell a patient that a medication is being used off-label, that is to say, we are using the medication but not for its intended purpose. In a very paradoxical and improbable way, one could actually conceive of using minoxidil off-label to treat hypertension. So the key to informed consent here is that we must provide information, the patient must have the capacity to understand the information, and the taking of the medication or doing a procedure must be voluntary. One could imagine scenarios where any one of these variables can be called into question, and each has its own unique set of moving parts. I'm going to briefly venture into this intriguing topic of informed consent, which Dr. Norris and I have both explored. So, capacity is not a fixed entity, and this drives lawyers crazy. And as I'm sure Dr. Norris will attest, the one most often called into question in CL is capacity. Capacity is fluid. For example, if grandma falls at the nursing home and is confused and disoriented, her level of capacity to a head CT without contrast is pretty low. It's almost at the level of a simple consent. That is to say, all that's required for capacity in consenting to the head CT without contrast is for grandma to say yes. That's because the risk of the head CT procedure is pretty low, and the potential benefit is very high. However, if grandma refuses the head CT, then the level of capacity for that very same procedure, only refusing it, is very high, and for the same reason. That's because there's very little risk but lots of gain, and if she's refusing, we want a very high level of capacity for her to refuse. This comes to the voluntary prong of informed consent. One certainly has a right to refuse a treatment, but there has to be a cogent reasoning process in the refusal. That's level of capacity. Let's take another situation. Say 95-year-old grandma has end-stage metastatic brain cancer and there's an experimental brain surgery available. What do you think the level of capacity making for this procedure should be? Now, if you said high, of course you're correct. That's because the risk of the procedure is very high and the benefits are low. The capacity required to consent to simple head CT without contrast is absolutely not the same capacity required to consent to brain surgery at end-stage disease for somebody who's 95 years old, or any age for that matter. Okay, we're going to hold it here because I'm going to expand this concept of informed consent, off-label prescribing, into our very existential role as physicians in my next program. I'm Dr. Renee Kohansky for the MD Edge Psychcast.
And that concludes episode 121 of the Psychcast. Let's get to this week's credits. The Psychcast is produced and the interview portion is hosted by the editor-in-chief of MD Edge Psychiatry, Dr. Lorenzo Norris. Our guest this week was Dr. Sheldon Preskorn. The Dr. RK segment is written, recorded, and produced by Dr. Renee Kohansky. The show notes are authored by Dr. Jacqueline Posada. The Psychcast is produced by MD Edge editors Gina Henderson and Jeff Bauer. All MD Edge podcasts are produced by our editor-in-chief and the editor-in-chief of Medscape, Dr. Ivan Aransky, as well as MD Edge executive editors Kathy Skarbeck and Mary Ellen Schneider, and multimedia editor Terry Rudd. Social media is produced by Kyla Clark. I'm your audio engineer, audio editor, and the voice of MD Edge podcasts, Nick Andrews. This is the Psychcast.